Morning, everyone. It's a privilege to open this plenary session on innovations in measurement methods. So across countries, there is a growing recognition that our current approaches to measuring health system performance must be updated to reflect the complexities of today's health systems. Data are increasingly abundant, yet they're often fragmented, incomplete, or poorly aligned with what we truly need to know about how health systems function. Traditional metrics, often focus on utilization, spending, or access, capture only fragments of performance and often fail to reflect how well health systems are delivering coordinated, high quality, and equitable care. The studies we'll hear about in this session demonstrate how digital data systems, longitudinal cohorts, international comparisons, and patient-reported outcomes can generate meaningful and actionable evidence for policy, practice, and improvement. With that, it's my pleasure to introduce our speakers and welcome them to the stage. Dr. Mahima Venkateswaran is a physician and global health researcher at the Norwegian Institute of Public Health. Her work focuses on the implementation of digital health registries, or e-registries, to improve tracking of maternal and child health outcomes. Dr. Irene Papanicolas is Professor of Health Services, Policy and Practice, and Director of the Center for Health System Sustainability at Brown University School of Public Health. Her research is focused on assessing the performance of health systems and furthering the use of health system comparisons to draw insights for national policymakers. Dr. Adam Wilcox, our next speaker, is Professor of Medicine and Director of the Center for Applied Clinical Informatics at WashU School of Medicine. His work centers on the design and implementation of health information systems and the methodological advancement of health informatics. And finally, Jennifer Bright is President and CEO of the International Consortium for Health Outcomes Measurement, ICHOM, which is a nonprofit that works with patients and clinical experts worldwide to define and deploy standardized tools to measure health outcomes. To begin, I'll start with our own work on the maternal and newborn health e-cohort, a study of the Quest network. So the maternal and newborn health e-cohort to track longitudinal care quality is a study led by myself, Professor Crook, and several other colleagues located in Ethiopia, India, Kenya, and South Africa, including several of them who are here, including Tefera, Jacinta from Kemri, and Dr. Sailesh Mohan. So the maternal and newborn health e-cohort was designed to address gaps in evidence on maternal and newborn health care. A lot of the data that we have in low and middle income countries has been focused on service utilization and measures of intervention coverage and access to care. We also have data on health outcomes, primarily maternal and newborn mortality, but there still is a gap in measures of processes of care and having enough data to understand what goes on when people access care and how it is that many people using healthcare services are still not able to achieve good health. When we do have data on care quality in low and middle income countries, there are several existing limitations. These data are often cross-sectional. They're often focused on inputs or structural readiness of health facilities. There's no long-term patient follow-up. The data makes it difficult to link processes to outcomes. There are often long recall periods, and the data is often limited to selected facilities. So the MNH e-cohort was designed to address these limitations. It's a study that is longitudinal and prospective. The data is collected in real time across the MNH continuum. It's focused on quality of care and the dimensions of quality highlighted here from the Lancet Global Health Commission framework. The data allows us to link process quality to outcomes, and it follows patients across the full continuum of maternal and newborn healthcare. So for this study, The women enrolled were recruited in the health system during their first ANC visit in health facilities. They were followed by a mobile health survey throughout pregnancy, through delivery, and until 8 weeks postpartum. And then we had another inline visit in person. This is largely a patient-reported study, but we were able to also add data extracted from source documents like maternal and child health cards. We conducted physical assessments, and we conducted a brief observation of the facility where the women were recruited. In total, we were able to enroll a little over 4,000 women across 8 sites in 4 countries. In Ethiopia and Kenya, we enrolled women in both public and private facilities. So this is the facility where they started their prenatal care. And in India and South Africa, we only enrolled women in the public sector. But these women did move throughout their pregnancy and postpartum period to different sectors as well. So in total, women were followed between 4 and 10 months, depending on the gestational age when they started prenatal care. And the data collection period was from April 2023 to January 2025. We were able to achieve reasonable retention rates, averaging around 84% across the 4 countries by the last N-line module at around 12 weeks postpartum. So a few key findings. The first thing that we looked at is the content of prenatal care visits. And we found that despite attending an average of 4.3 total prenatal care visits throughout pregnancy, pregnant women received only between 46 and 79% of recommended care during pregnancy, according to national guidelines. There were important gaps in history taking, in screenings, in counseling, and in treatments. Another thing that we looked at is the prevalence of risk factors, and we found relatively high, a high prevalence of pregnancy risk factors, including anemia, chronic illnesses, malnutrition, and previous obstetric complications or C-sections. These conditions are linked to poor outcomes at birth. And in one of the first analysis, we looked at the association between having some of these risk factors and the content and quality of the first ANC visit. And we found that unfortunately, there was little to no association between having risk factors and the completeness of the ANC visit. In contrast, in Ethiopia and Kenya, women who were wealthier or more educated were more likely to have a more complete ANC visit. In India and South Africa, we actually found that women with risk factors were actually less likely to get an ultrasound at their first visit, revealing important socioeconomic inequality in care quality and poor quality risk detection in prenatal care. We also looked at the continuity of care in follow-up prenatal care visits, and we found that although the vast majority of these women got at least 1 blood and urine test, there was poor continuity of care in terms of receiving the minimum recommended of blood and urine tests, which is 3 or 1 per trimester. In Ethiopia and Kenya, less than 1/5 of women actually receive this minimum of 3 blood and urine tests during pregnancy. These are crucial for detecting anemia, infections, diabetes, and preeclampsia, among other things. We also found that in Ethiopia and Kenya, ANC quality actually tended to decline as the pregnancy progressed. So women who would report a new prenatal care visit in 2nd or 3rd trimester were less likely to report receiving basic things like having your blood pressure measure or your weight measure. And finally, we also found complex care patterns. So these graphs are showing the average number of different healthcare facilities that women visited from the first ANC visit to 8 weeks postpartum On average, women would go to 3 different facilities. Some went to as many as 8 or 10. These facilities are not connected by EMR. There was a mix of public and private, as well as primary and tertiary care facilities, meaning that the health system may be having difficulty providing continuous care. So we also looked in some analyses at the association between quality ANC and maternal and newborn outcome. We found that quality ANC reduced the risk of late miscarriages and stillbirths. And we also found that better quality ANC was associated with a reduced risk of intrapartum complications or poor postpartum health. So these are just some of the initial findings from the e-cohort. In future analyses, we'll be looking at delivery care and the postpartum period. But so far what these data have shown is that there are important missed opportunities to improve maternal and newborn outcomes, primarily in the prenatal period. The continuity and consistency of care across pregnancy was poor, and important risk factors like anemia, malnutrition, depression, and previous obstetric complications were often not detected and not even addressed during the visits. The quality drop-off that we found in the second and third trimesters in Ethiopia and Kenya are also concerning, given that this is a period where obstetric complications arise that could be addressed with high-quality care. And essentially, these findings also highlight the importance of monitoring longitudinal care quality and looking at number and timing of specific interventions, not just whether they are performed only once. So these are all my slides for this. If you want to learn more about this project and the e-cohort, feel free to visit our website. I'm going to hand it over to Dr. Mahima.
Thank you. Thank you so much for having me and for this invitation to present. I'm a researcher at the Norwegian Institute of Public Health, working as part of this group called e-registries. So over the years, we have tried different names for what this group is called, just trying to test out what works best. So we'll see. So right now, we're calling it digital health registries to improve quality of data and care. Okay, so by digital health registries or e-registries, we mean systems that allow for uniform individual level longitudinal data that's digitized at the point of generation, not after the fact. By point of generation here, I mean they have to be recorded when the client is interacting with the provider and not after that consultation is complete. So this information in an e-registry system has to be exchanged at all levels of the health system, or at least allow for the exchange to happen. And the goal is to support care providers, clients, and their routine reporting needs. So we operate with the public health context on one side and the digital health context on the other, and try to combine these two worlds. So keep the focus on public health, improving data quality and improving health systems, while also using, for example, normative guidance from the WHO for guideline recommendations for digital health interventions, or the digital adaptation kit for antenatal care that was released recently in an attempt to help countries implement smart guidelines in practice. So if you think of how we operationalize e-registries, we're now looking at individual client level data that essentially enter into a system and creates this longitudinal data collection backbone, or what we call the e-registries. So this is it. So the moment this longitudinal data from the client-provider interaction enters into a system like the e-registry, it's now available for use by healthcare providers. We can provide clinical decision support. The exact same source of data can also provide targeted client communication. The logic behind this being that a younger mother that has her first pregnancy has a very different risk profile than a mother that has had 5 pregnancies before and is pregnant for the 6th time. Giving them the same health education information probably does not make sense, and a system like this can help them give targeted communication. For health system managers, this means they now have a data source that is of high quality, that's actionable and in real time. For example, if the data managers or the health system managers are able to get a dashboard, they can then look at this dashboard with data of indicators that actually matter to the healthcare providers on the care that they give clients. And for policymakers, they're left with a system that's based on national digital health policy, as well as integrating clinical guidelines for care. So all of this is achieved, at least in theory, by a single digitized health record, which can then drive several different interventions. So this is what we mean. I'm just trying to explain what this looks like when we start implementing this in a health information system. So the clinical data points that are entered into individual client-based paper records. This is, I'm just going to explain first, a typical health information system that you might find in any setting. So the pregnant woman comes in, all her data are entered by the healthcare provider into, let's say, a paper record. Following this, there's some manual counting of events and followed by monthly aggregate reports. Again, the frequency of this might vary from one setting to another, but this is just an overall example. So all of this data then enters into a routine health information system report that is aggregated at the clinic level. And then there is some manual diagnosis that happens. When I say manual, I mean the clinician makes a diagnosis and does a referral. And then they prepare reports of this that they either send to the district or to a higher level. And this could be, for example, on maternal conditions. This could be on the number of antenatal care visits and so on. Followed by which you have the paper reports that are then computerized by dedicated staff. So even in systems where there are currently digitized by open source software, the digitization actually happens at a much lower level when all of these reports that have been aggregated until at that point are then entered into a system. And these reports are sometimes published, sometimes not available openly, but in any case, there's some report that comes out of a health system on these event counts, for example, number of antenatal care visits, what services were delivered, whether there was blood pressure measurements done, for example. Now, what happens if this routine health information system is transformed? So now, if you implement a system like an e-registry, what essentially happens is this. So you're removing all of these steps in aggregation that happen from the point of generation at the client-provider interaction, and then you can produce these reports. You can aggregate them for the individual, at the clinic level, district, or national data. Okay, so what did we do? So we did some studies to understand what happens when such paper-based systems that are prevalent everywhere are then converted into this individual data-based digital registries, and what happens and what are the consequences of that. So we looked at health status, health system performance, and policy. So essentially what we were trying to look at was the change in the quality of the data, in the nature of the data. So we are now going from a system that has count data based on numerators to data that that you can actually produce indicators from, which means we finally have a denominator that we can trust. The second thing that happens is the contact coverage in antenatal care is now slowly moving into being able to measure effective coverage of antenatal care interventions. So Catherine also had this in her presentation about how just measuring if something happens once is probably not enough. We have to measure if there is continuity of care, if the woman, or the pregnant woman in this case, gets what she is supposed to get throughout her pregnancy. And you go from having no data on processes of care to actually having data on processes of care. So if, for example, the anemia screening happened as it was supposed to happen. So in this first case, where we tried to look at what happens to the health status. So here our objective was to calculate routinely reported indicators. So exactly the same indicators as the health worker would calculate or report on, but using individual level clinical data. And we also wanted to avoid getting mixed up with what could be effects of just digitization. So we took a bunch of antenatal care paper records and digitized them, essentially mimicking what we would call an e-registry. And then we compared these indicators with what were reported in the existing health information system, that is paper-based. So the data sources we used were individual paper-based records, as I just mentioned. And we collected aggregate reports from health facilities and also from the district and the national level for the exact same clinics. So we did descriptive data of these reporting indicators, nothing fancy. And we first looked at common indicators like maternal age. So here you see they are quite comparable. So on the left, you see clinic reports and national reports. So these are from the paper-based aggregate reporting as they would do. And this is what happens if you calculate the same indicators from individual level data. So this is anemia at 36 weeks. And this is also looking okay. This is clinic reports and national reports. And then you have the clinical records data, quite comparable still. And then we come to anemia screening at 36 weeks. So the reports from the clinics and the national reports from the health information system are very different from what you would get if you actually calculate how many women were screened for anemia at 36 weeks. So we then looked at some of these conditions. These are also conditions that are supposed to be reported by the health worker, manual aggregation as I mentioned. So we first looked at the district reports and the national reports. So all of these conditions go from referral clinics, which is also not uncommon in many of these settings. And then we calculated the exact same indicators with the exact same definition as they're supposed to apply in a health information system using the clinical records data. So there's some difference as you see across all of these conditions, but the moment you start making the indicator a bit more complicated, for example, there is a hemoglobin value that health workers need to take into account and there is an exact cutoff, then there was quite a significant difference between what was reported and what is actually the situation. The second case study, we tried to calculate coverage of one screening, the appropriate number of screenings of antenatal care interventions, and what we call the effective coverage of antenatal care interventions. So very similar to what Catherine presented, but the data source is quite different. So it comes from the patient records or the individual records in this case. So we did three sets of metrics. So the first metric was one screening of a specific condition, appropriate number of screenings, and then if there was appropriate number of screenings at the right time. So as you see here, this was the definitions that we followed, and this is based on the guidelines in the setting we studied. So this is screening for hypertension, for example, it has to happen 5 times during pregnancy based on the national guidelines. Fundal height measurement has to happen 4 times, screening for anemia thrice, antenatal ultrasound thrice, twice for diabetes, and there are some tests that are done only once. So this is the results that we found. So the first thing is screening for hypertension, and then we have symphysis fundal height measurement, and this is at least one screening. So this is the kind of indicators that are most commonly produced, and also this is the kind of indicators for which you have data. Now, if you look at what happens if you take the appropriate number of screenings into account, that is already a big drop. And then if you take number of screenings done at the right time during pregnancy. So if you have anemia screening, that has to be done during the first trimester, 24, 28 weeks, and 36 weeks. So if you now start taking this into account, then the coverage falls further. It's looking slightly better if you look at some conditions that have to be screened once. For example, if you have to do a urine test to check asymptomatic bacteriuria, and this is done once in this health system, and screening for RH type. So these are things that are done once, and so the difference in the coverage levels is not as dramatic as would happen when the tests have to be done repeatedly. So we also looked at any 5 visits, right? So we checked what's the coverage of any 5 antenatal care visits. 5 was the recommendation according to the national guidelines. It's now changed, of course, to 8, at least 8. So this was 48%. But the moment we started looking at timeliness of the visit. So we took the gestational age data and checked if the women are coming according to the time they are supposed to come during pregnancy. This is important because there are certain interventions that need to happen at specific times during pregnancy, and now the coverage will drop dramatically from 48% to 13%. The first up here is also the kind of data that you would typically have access to and you typically report on and monitor to see if a health system is doing better, at least for maternal and child health. So the third case study we did was to take all of these available data sources to us. So there was this routine data produced by the health system and the health information system. We took a population-based survey that was available, took paper-based records and the e-registry. At this point, we had managed to implement the e-registry, and then checked what happens if you enter all of them into a commonly used modeling tool like the LifeSave tool. We did 5 context-specific coverage indicators and derived from each of these data sources if they were available, and did list or LifeSave tool projections and looked at the difference in number of deaths and anemia cases averted by using all of these different data sources. So this is the availability of data. So okay, thanks. The aggregate routine reports had 2 of the 5 coverage indicators. It did not have any of the aggregate, the health status indicators needed for list modeling. The mixed data as a household survey data that had 3 of 5 and none of the health status indicators. The paper-based records had all of the coverage indicators available and also the health status indicators because you get clinical data from records. The e-registry was similar because the paper-based and the e-registry system are supposed to mimic each other. So here is the first thing is the routine data. It shows you some changes in the maternal life saved, the newborn life saved, and stillbirths averted. This is the survey data. The newborn life saved is still at 0. And this is the data from the paper-based records, and this is the data from the e-registry. So there is not so dramatic differences, but there are some differences here. And in a different setting where with higher mortality, this could be different and drastically change decisions, or at least the evidence available for decisions based on the data that's available. So the anemia cases here, the paper-based records had showed there were 16,000 anemia cases. I'm done, almost done. While with the e-registry, there were a lot more anemia cases that could be averted. I'm probably going to skip this and just show you that the conditions that have to be tackled in order to avert maternal mortality was also quite different depending on the data sources that you choose. Thank you.
Thank you, everyone, and good morning. It's a pleasure to be here to talk to you about the Iconic Collaborative and the work we've been doing to try to compare patient trajectories of care across countries. So I just wanted to start by putting this into context. As we've heard in this panel and many others, health systems around the world may be different, but they're facing very similar and new challenges. There's a population that's aging, increasing burden of chronic disease and multimorbidity, and challenges of maintaining health spending while meeting these goals. At the same time, addressing these challenges requires changing the way health systems provide care. Health systems have been built really to treat acute care conditions, and in this new environment of an aging population and increasing multimorbidity, we need more emphasis on prevention and diagnosis, coordination of care across settings, and really looking across boundaries, seeing what innovative care models there are happening and how we can try to learn from them and adopt them in our own countries. But current measures of health system performance really still reflect past needs and priorities. Too many comparisons are static in the indicators that they compare. They'll look at one interaction within a single point in time, which is not fit for purpose if you're trying to understand coordination of care or how somebody experiences the care journey. They're often very acute care focused. Most international comparisons will look at indicators of performance within the hospital and miss other important care settings like primary care, community care. And they often do not adequately capture all of the outcomes that matter to patients and the population. We have too many indicators focused on mortality and not enough on how patients experience care and other aspects of their care journey that matter to them, such as how long they're spending in an institution and where they will receive different care. And these are the challenges that we try to address with the Iconic Collaborative, where we try to produce health system comparisons that allow us to measure the system and the care the system delivers in a dynamic way across countries. To do this, we use high-quality linked claims data and registry data across countries and try to compare what a care trajectory would look like for the same type of patient experiencing care across countries. We focus on high-need, high-cost patients, as these are patients that are likely to have multiple interactions with the health system over the course of their care. To date, we've focused on 4 patient personas, as we call them, or types of patients across our health systems. These are an older adult with hip fracture, an older adult with multimorbidity, and so that cohort has been focused on somebody who has congestive heart failure with diabetes, and also in a subsample of that, also COPD. We've been looking at a dementia cohort more recently and a younger person with serious mental illness. These personas came or were motivated by some work done about a decade ago, published in this NAM a report focusing on a taxonomy for high-need, high-cost patients. And so the idea is that while they represent these people who interact frequently and have high needs, they also represent different types of patients who will interact with different parts of the health system. So the International Collaborative on Costs, Outcomes, and Needs in Care, or ICONIC, is currently comprised of 18 countries across the world, and a lot of people within those countries that have access to the data, analyze the data, and work together to interpret the data. The way we work is that we first try to construct our harmonized patient cohort. So we have the idea of the patient that we want to compare, and then we go into the data. In some cases where the data requires identification from a hospital admission, something like hip fracture, this can be relatively straightforward as we're relying on diagnostic codes that are somewhat well standardized across countries, and we can just look at how differently they're applied. In other cases, such as our dementia cohort, this can be very, very challenging, as patients might be diagnosed at different times in their care journey. They also might be diagnosed in different settings in the system. Often codes outside the hospital are not harmonized across countries. And so we're really trying to see what is the way that we can identify a like-for-like population that we can follow through the system. If we can't identify this, our care trajectories are then not comparable and not reflecting just performance differences. So this step can take us quite a long time to comprise these cohorts. Once we have these cohorts, We will have a team lead, and this can vary depending on which nation is driving which analysis, who will construct a data sheet with all of the variables that we're interested in looking at, comprising the care journey and analyses of the care journey. So we will then go back and do the same process of trying to standardize these variables across countries. And this too can take a long time. I can't tell you how many days we've talked about what is rehab, where does this one interaction happen? How many times do you interact with the health system if you have an X-ray? And we try to do that, and I think actually a lot of the value is in kind of trying to understand these harmonizations or these differences. We then go back, everybody runs the analysis, and we produce these standardized comparable findings that we can use to compare performance across countries. So in our first phase of work, we just started with, okay, we identify the same patient. Here it's the patient, the older patient with hip fracture. We look across all of the countries and we document the utilization of care that they experience over the next 365 days following the hip fracture. We look at the amount of acute care they receive, how many hospitalizations, how many emergency room visits, how long, what do these cost, where do they get post-acute rehab care, how long does this last, how many visits, what does this cost, how many primary care visits, who do they see when they go to the primary care setting? Is this in person, by email, is it a doctor or a nurse? How many outpatient specialty visits, how many pharmaceuticals are they on? How much does a year of care cost? And importantly, what are the outcomes at the end of the year? How many people have survived? How many people have been readmitted multiple times? How long are people spending in institutional care? When we first did this, we found a lot of variation across countries, a lot of variation in where people get care, what the relative proportions of primary to specialist, acute care rehab versus institutional-based rehab in other settings versus home care, suggesting that countries deliver care very differently and big variations in outcomes. So this likely matters as well as in spending. So understanding this could be beneficial for everybody in terms of learning what works better and are there lower cost, higher quality alternatives that we can adapt across systems. In more recent analyses, we've been working within those cohorts to try to identify these small areas of health system improvement where we can find differences that we can leverage to identify where we can make changes that could benefit these patients in every country. So some of our current work is focusing on our hip fracture persona, looking at deprescription of high-risk fracture meds following the fracture itself. So there's many medications that can make patients just more at risk of falling and sustaining then another hip fracture. We're interested in how much do health systems have different baseline use of these meds before the hip fracture, and how much do they then deprescribe these meds after the hip fracture occurs. So what you can see is across some of our study countries, we see very big rates, and this is just one of the drugs that we're looking at in benzodiazepines before the hip fracture, with nearly 44% of our cohort on these drugs in France, but in the US only about 16%. And then we also see very big rates, differences in how much deprescription there is of these after the hip fracture. So you see that, again, big differences in how much they're able to reduce the deprescription of this. We're also interested in where does this happen? What are practices that encourage the health system to do this? And can we find how, using all of this detailed patient-level data, the association between this and outcomes within the following year? So differences in mortality, refracture, or readmission. Another project we're working on currently is understanding when systems diagnose patients with dementia. So different systems have different approaches to dementia diagnosis. One of our countries, Korea, does biannual population cognitive screening in their entire population aged over 60. In the UK, there's a primary care financial incentive in their pay-for-performance scheme. You can see that BBC article there, trying to promote diagnosis. Other countries don't have active policies on dementia diagnosis, but just raising awareness within society. So what we're doing here is linking our claims data with surveys that measure repeated measures of cognition over time and are representative of the general population. So with the linked data, we can identify in a comparable way when people start to present symptoms of cognitive decline and look at the linked data to see when they receive a diagnosis of dementia in their different countries, and then follow the pathway of care, really with more of a like-for-like cohort to understand both when timing of diagnosis varies, but also what implications that has for utilization costs and outcomes. So we've had many challenges, but we also believe there are many opportunities for this work. I realized too late that I only put the challenges on the slide, but hopefully I've convinced you that there are a lot of opportunities and lessons to be learned by comparing these care trajectories. And some of the challenges I've already mentioned. Data access and linkage can be very time-consuming and difficult within countries, especially if you're trying to get the same data across countries and do that in a timely way. Data harmonization is very tricky, both for defining the cohort and the care settings, and funding to support all country partners can be very challenging. Nevertheless, we believe the work is worth it, and the variations that we've seen certainly suggest to us that there's so much opportunity for learning. Thank you very much for your time.
So I consider myself a data person, and so it's a little shift in direction because I'm not actually going to show any data. I'm going to tell a story, and it's relating to policy and about data, but I'm not showing any, which was kind of a little strange. But the two, and I'm not going to, I don't have an international story. This is pretty local, but let me give the background. So in terms of policy, there have been two major policies that affect data and public health. You know about these, the HIPAA privacy rule almost 30 years ago, which established that covered entities may disclose PHI to a public health authority. It's kind of that exclusion. And then meaningful use about 15 years ago that built up the infrastructure for electronic health record data to be used. And one of the core benefits that was stated for justifying meaningful use in that investment was the third goal to promote public and population health. Moving forward about 5 years ago, I was the chief analytics officer at WashU Medicine in the University of Washington in Seattle in March 2020 when the first identified outbreak of COVID happened in the United States. And so this was from March, a heat map that we had of the spread of COVID as it was going on. It was an interesting time because very quickly with that outbreak and the testing that we were doing, we had more data on COVID in one day than the rest of the country combined had within a week. Now, hit June and everyone has enough COVID going around in their systems that it didn't like what was going on. We were all experiencing it, and so we all recall that. But for a brief period of time there was a real hunger for data and how to use it. As we were going through this, kind of when you're right in the middle of it, you get somewhat of a fog of war in trying to address all of the data issues. I did have a colleague who was working at the CDC that I reached out to and said, we've got probably more data than you have locally in terms of what we're seeing, recognizing that a lot of people are wondering how this spread is happening, what we can learn from it. How can I be helpful to you? Which he was thrilled with, and then sent me a request for this, which I found very funny. Because and it makes sense to me that he would want this request in terms of similar to the MMWR weekly reporting, but when I count that's 105 data cells that they're asking me to fill out for our institution in order to send this to them, which I was kind of starting to do it. And then in our institution, they said, you can't send that to the CDC because we don't have a data use agreement with them. And I said, you don't need a data, I'm starting to repeat the HIPAA rules. And well, that may be the law, but institutionally, this is how we've established it. And so, and so I'm hitting up against these internal policies that are misinterpretations of the federal policy. Needless to say, this was really, really hard to try and get out to the CDC at a time when you would have thought that would have been the #1 priority. Although when you're working locally, this was not the only data request. During the middle of COVID with data, we weren't wondering what data we can provide necessarily. We were pretty busy in a lot of things. That's kind of the fog of war that was there. So like, what did we really learn from that experience? Number one, that institutional misunderstanding of the rules of data sharing were really important, and that put a significant delay in being able to respond at a time that delays were really critical. It was a complex data request that was being asked. I was hoping that they wanted, 2 queries, not 105. Oh, and then they said quickly, and we would like this for all races and ethnicity. So then you multiply that. I think it was effectively 500 cells of data that they were requesting per week. And so we were unable to really divert the resources necessary in order to provide that data in that emergency. And I want to reflect on this, that why this didn't work really well is because it was kind of a reactive approach. Even though the policies had established that this is what we should be using for, we didn't do very well. So fast forward a little bit, a group of at Boston Children's Hospital led by Ken Mandel had this idea, which they called Cumulus, to build out a distributable query system that leverages fire services, and fire services had been required mandated by the 21st Century Cures Act, that we would have, that they would be able to build this infrastructure where public health organizations would be able to query the systems directly. So those 105 metrics that they were interested in, that would have been much easier to provide if we had a system where they could just automatically query that information from the CDC or from another public health organization. So it was kind of really a much more proactive approach to it, where the agreements and the infrastructure would be defined in advance, which I was all on board, having lived that other challenge of being reactive to this problem, even though the policies had been set to support it. Here's the diagram. I'm not going to go through the details of this really, but it's basically you're doing a federated system where the queries are distributed, you run it locally, and then the information that gets distributed back to the public health in terms of the numbers. So there's, even though it's allowed to send the PHI, it's not really sending it across the wires. It's still federated, which makes the agreements easier to make. But it was, now, they did this initially at Boston Children's, which had Cerner, now Oracle, so one EHR, and they wanted to demonstrate doing this across a whole bunch of EHRs, or at least the other one, which is Epic. And so they did this with 5 other institutions. So we as a group were working together to try and establish this capability. And again, just because there's a policy set that means we can share data doesn't mean we do it effectively. Just because there's a mandated policy of using FHIR doesn't necessarily mean that it works. So here was the great lesson here. So we eventually got it worked out, but it took at least twice as long as we thought it was going to do, because of the difficulty of breaking new ground. This had never been done before, but still I was very glad that they were trying to do it, because we were doing it as a demonstration rather than trying to do it in the middle of a pandemic. The technology was still untested, and the fire services still had errors, and the NLP capability it was part of that was still emerging. But there was real value in working with multiple teams, because if they had just extended it with us and we were trying to do that with our Epic system, it would have taken a long time to realize that the problem wasn't us, it was actually the Epic system. When we had 5 people working together and all hit on the same problem, we then were able to work with Epic directly and try and fix those issues. So that was really huge. And then it was helpful to have the shared vision of the program goals across the system. So that was a valuable lesson there, and I just want to give, but it's kind of an interesting story about how just the policies may be set in place, but until you actually try and implement it in a proactive way with a demonstration project like this, you're going to be finding yourselves with a lot of challenges to overcome. Thank you.
Morning, everyone. I always dread and like being at the end of a panel discussion. I love it because I'm a learner, so I got so many things from the prior presentations. I dread it because I have to make sure we end on time. And I stand between you and your great questions. So I will make my slides available for anybody who wants them, because they are data rich, and I'm going to fly fast. So first, the International Consortium for Health Outcomes Measurement is a US nonprofit. We were created 13 years ago. with the very simple premise that we need to do something fundamentally different in the kinds of data we use to make decisions, both at the clinical level all the way up to the policy level. So we have very common DNA with all of our presentations. We come at it from a slightly different angle in that the focus is on what are the outcomes, the results of care that are most important to the patients being treated, divided by the resources used to achieve those outcomes. That is our formula at ICHOM for value. And our imagination is, what if we could fundamentally redesign the care delivery system? And this is on a global level, not just here in the US, to really focus on, are we delivering the care and the results that patients want, expect, deserve? And this has multiple dimensions. So that is how and why ICHOM was born as an organization. What do we do? Our principal area of work for the last 12 years has been to gather international working groups that include clinicians, people with lived experience, researchers like yourself, in asking the question, what are the domains and the outcomes that are most important to people living with these health conditions? To date, we've mapped 47 different health conditions, including cross-cutting sets for healthy child, healthy adult, older adult. So these resources are in the public domain, freely available and used all over the globe as a backbone for the data system. So for example, what Mahima was sharing about e-registries, I'll share in a moment a couple of examples of how our sets become the data structure for the creation of registries. And they're used at both the clinic and the macro, national level, as well as at policy levels on an increasing basis. So just a couple of examples to share with you, what does a set look like? So when we talk about heart failure, the sets include both clinical outcome measures, traditional aspects that are often in electronic health records, if those are used, but they also include patient-reported outcome measures, which, as you know, is a growing thing here in the United States. Suddenly we've discovered that they exist, but they are used all over the world to collect direct from the patient, what are their experience of care, what is their mental health status, what is their functioning level, things like that. We also include time points, so to the point of how often do you create longitudinal data, you need to follow over time. A lot of this data is collected, varies by health condition, but it might be at baseline, at 6 months, at 9 months, at a year, for example. It varies, again, by the set. And then we also include case mix variables. And we do this from a comprehensive standpoint. A lot of the working group members that were involved foresaw that this is not just about clinical real-time data coming back to the clinical context, but it's also about being able to track public health and population health level data. So it was designed to be forward-thinking in terms of the meaningful use, to use Adam's phraseology. This is just another example of our adult obesity set. This was published last July, or it was just published in the Lancet, but it was released last July. And of note, it tackled some interesting and new issues in the realm of obesity. For example, not just focusing on BMI as the primary indicator of obesity level. So looking at more holistically at what the clinical markers were, but also focusing on things like sleep, on like pain, like functioning for individuals who are confronting obesity. And so making, if you will, the concept here is we really have created a data architecture that supports whole health thinking in real time in a clinical context. The only thing I want you to get from this slide is that standardization is really important, and that's something that is why we created this library. It's not a hold everybody's feet to the fire thing where you're black or white, but the focus on comparability of data is so important, and you heard that in all the prior presentations. So that is really what we see, and we also think that establishing what are the outcomes that are most important to patients in these health conditions drives different conversations about how do we gather this data. So we're dealing with new digital ways of capturing information like sleep and other things that are important to patients. Now we have AI, but if we don't start with a common definition of what are the important outcomes that we are striving for in a healthcare system, it gets much harder to discern how we compare one clinic to one clinic, one health system to one health system, one country to one country. So let me just give you a couple of examples before we take some questions. First is a registry example, which I'm happy I picked given the presentation of the e-registries. But this is a hospital system in Germany called Helios that has selected the heart failure set as the backbone of its registry that it is hosting countrywide. And so this makes it one of the largest in a specific health condition. And this just shows you the number of patients involved and what they're doing. I'm hoping that we begin to see some of the papers coming out of it, but it's principally designed to give feedback into the clinical context about, are we achieving the outcomes we should be in heart failure and on a national level? Second example is related to Bangkok, Pattaya. This is just an example of where this is happening all over the world, as you've heard from the prior speaker examples. But this is, again, about heart failure. Interestingly, it wasn't just about readmission rates, but we also saw physical functioning, a big focus on decreased depression symptoms, which is often overlooked, right? Especially like pregnancy and childbirth. I noted that mental health screening and mental health was not a part, and urinary incontinence is also, those are in our set as being primary outcomes of important to pregnant moms, for example. And then they also took this data and brought it back into how do they improve their multidisciplinary clinical approach to patients with heart failure. So again, bringing those mental health professionals into the clinical context. It's not just about the heart. The next example is from a specialty hospital in Mexico called Kaipadi, focused on diabetes. They implemented the entire ICHOM diabetes set, and the significant ones were not just about the glycemic control, although those were pretty significant improvements over the course of several years. But two things that are on everybody's mind is cost reduction. They saw an almost 80% drop in the cost per patient from like $2,300 per patient to $592. A lot of that had to do with service utilization. So patients that were better managed in their glycemic control and their anxiety about time and range didn't need to have clinic visits as often. Another one from Singapore having to do with stroke, again, and reducing inappropriate care. So one of our goals is not just better outcomes, but reducing unwarranted care variation, making sure that we're optimizing the care delivery for the population and making room for patients that can't currently be seen because of the unavailability of clinician time. And then the last, I think this is my last example, it has to do with voice of the patient. So I'm not a clinician or a researcher. I've learned along the way from some really amazing people. I am at my heart a patient advocate. So for me and my role at ICHOM, it's all about, are we meeting the needs of patients and families? And that starts with the outcomes they care about. This initiative in Australia was started by an actuarial firm of all things, focused on what are the outcomes that are important to patients and bringing that data back into both clinical provider networks as well as payers. So this is a great example of where we have to partner not just across countries, but we need to partner across stakeholder groups, patients, clinicians, and the financial side, the payer and employer sides coming together to center care transformation, but starting with the lens of, are we achieving the outcomes that are most important to patients? This is another registry that's in development, and I just leave you with those 47 sets are used in over 600 hospital and other healthcare settings all over the world. ICHOM is a resource to all of you. I look forward to exploring some partnering with some of my co-panelists, but if we can be useful to you, our sets are freely available and used in multiple ways, and we'd be glad to talk with you about how to do so. So thank you for that moment, and I think we may have time for a couple questions. Thanks.
Thank you, everyone, for these great presentations. Yeah. I want to start with maybe one question for perhaps both Irene and Adam. I was wondering if you could speak a little more to essentially in aggregating data and collecting patient level information from multiple countries and institutions, Can you speak a little bit more to some of the data privacy barriers you've faced? And also, what have you found most effective in building trust to promote data sharing across institutions and public health agencies?
Thanks for that question. We can't share the data. So the patient level data has to stay within the research organization that has the access to the data, which makes it very incredibly difficult both to harmonize and to conduct analyses across. So we have kind of a hub and spokes model where all of the data partners really have to come together and understand each other's data without seeing it so that we can harmonize it. We try to standardize variables, and the process takes a long time, and then try to build on these federated methods for analyses. But that is one of the biggest challenges, that the data can never be in a single place, and so we really rely on our local partners to do a lot of it.
Yeah, so and extending off of that, I've found that data sharing is possible, but it's usually very difficult because it's not incentivized. It's actually disincentivized. I brought up HIPAA for a reason, because we've been living for 30 years with disincentives for data sharing. They were strengthened with penalties under high tech in 2009, so like 15 years. And the challenge with that is that we're limited because of those disincentives in terms of what we share, and we need to kind of have counter incentives. So these demonstrations of what people can do and have been able to do with data become very important, because ultimately people have to say, I want something like that, enough that I'm going to facilitate our being able to do that. And I think those will break down the barriers. Every time I've seen an issue of like, we need to share data, if there is enough will behind it, you can actually get it done. Like at research levels and other things, you can figure out how to do it with collaborations. It's just really hard because you're going against pretty strong disincentives for doing it. And I think those disincentives are important. I think patient privacy is really critical, but we're now to a point where we've shown the capability to do this, and we can find ways to do it safely. I do think AI is going to push us really hard this way, because it requires data more than the use and sharing of data more than we've ever done. So 5 years from now, I think this will look a lot different.
Great, please go ahead.
Can I just add one thing? And that is one of the things that doesn't get addressed a lot, and I would love to explore further, is the role of the patient in receiving and activating on the data that's collected from them. So a lot of the feedback loop that I think would solve some of these, it's hard to get consent and things like that, is thinking about it from the patient perspective. There are examples already of when data from patient-reported outcome measures are brought back into the clinical context, not just to the clinician, but to the patient, and they see, here's how I'm doing compared to 6 months ago. It's not only activating from a self-management standpoint, it's also increases engagement rates, it increases the production of the patient-reported outcome data insights, it improves consenting, all of those things. So to some degree, we tend to get trapped in it's the technology or the legal aspects of data sharing that are hampering us. I actually think if we would start to recognize that the patient is an equal partner and equal owner of that data, it would start to shift the conversation a little bit.
Thank you. I think we're almost at time, but if there's perhaps just one burning question from the audience, please raise your hand. Professor Crook.
Thank you so much. Thank you. And thank you all for what a great diverse set of presentations, but also some very core similarities here in concern around these innovations in measurement. I think the question I get asked a lot, and I love measurement and I love data and I've learned a lot, is the use case for these findings, for these measures. And to your point, Jennifer, also one of the use cases could be that we're informing patients, helping them understand where they are comparatively to themselves or others. But I guess I would love to hear maybe just very briefly from each of you, can you, and I think Jennifer, you did that actually already in your presentation, showing that these data were used to motivate changes in care. It's a tall order. We're researchers. We don't run health systems. But I would love to just hear just a brief reflection, Irene, from you, for example, Adam, others. Do we see uptake? And who cares? Who cares about these results besides us?
Happy to start with an example. I truly believe comparisons can be very powerful in that they force you to take a different perspective. When we first did our first hip fracture patient, we had some comparative mortality results at the end of the year, and the UK did really badly. And these were not new outcomes. They had been published just without reference to any other countries. But once you saw the difference to other countries, it was stark how different they were. And this got a lot of attention. And then, of course, the question is why? And what was powerful is being able to look at that journey from patients to start to think about what is different between those other countries. And so I think it's both the broader perspective that a finding on its own might not, raise alarm bells, but when you see it's very, like, how different it is, it can. And then the power to be able to go back and look at the data and look at those differences to try to formulate some hypotheses.
Yeah, and I'll just reemphasize the incentives and the changing incentives. The more we see what other people are able to do with data, the more we want that enough that we're willing to take risks. Whereas for 20 years, we have been, our goal was not to make the Office of Civil Rights wall of shame of breaches, but now that everyone's on the wall, and there are other methods for protecting the data, I think people can be more creative about doing that. But good examples drive us to take those risks.
So in the settings that we work in, one of the main incentives is if you can automatize the reporting systems. So in every single implementation that we have done, that's like the primary request of a health worker. So what they want is to reduce the burden of documentation. So if you can give them a system that helps them do that, then they're very motivated. So then this is despite all the other challenges such as internet and electricity, etc. So as long as there is a way that they don't have to do this huge reporting that they do every day, every month, depending on the setting, that's been a huge incentive.
I'll just add that I think, I forget whose slide it was, but that I think it was Irene's, irrespective of policy, politics, health system structure, the challenges that face health systems worldwide are the same. We have the same top 5 chronic illnesses. We have aging populations. We have rising proportion of GDP being spent on healthcare. We have, poor outcomes. Like, it's all the same. The incentives can happen at the micro level clinically, and they can happen at the policy level. We see increasing number of ministries of health and governments establishing outcomes and specifically patient-reported outcome measures as a primary metric of what quality should look like and driving payment systems. So we're starting to see that lever. And we're also seeing major multinational employers really are fed up with just being told that they have to pay more money. And they're starting to lean into this and lean into the notion that they drive conversations with payers in demanding different results for the money that they're investing in healthcare. So I think will be really interesting to have this conversation a few years from now and see where we are.
I think for the e-cohort findings that I presented, that question is hard to answer because these results are brand new, recently analyzed. But I hope they'll be helpful in helping countries and governments design improvement initiatives. And I invite you to ask our country partners who are at the conference about what discussions already have taken place in countries. I think we're at time, so thank you very much, and please join me in thanking our speakers today.